Thank you very much, Shannon. I'd now like to introduce Dr. Brandon Ramakko, who is a chiropractor at the DaVinci Center, who's going to be giving us a presentation entitled Trauma, Central Sensitization and Chronic Pain Syndromes. Please help me welcome Dr. Brandon Ramakko.
Okay, I have an ambitious plan for today. My goodness, just 15 minutes, let's see. So my outline today, I have a lot of questions I'm going to try to answer. I'm going to try to answer, what, why, and how of pain. What is central sensitization? What is a chronic pain syndrome? How does trauma relate to chronic pain later in life? And what can we do about it? So pain. Why? In radiology, there's a particular finding, it's a radiology study of reading x-rays, a particular finding called a Charcot foot or a Charcot joint. And when a radiologist sees this x-ray, he doesn't know how to even describe it. It's not a fracture here, it's not some arthritis there. The joint looks destroyed. It's disorganized. The foot looks like a bag of bones. And how does something become like that? Well, it becomes like that in individuals if they lose their senses in their extremities. They can't feel. How do you know you've stubbed your toe? Well, pain. How do you know you need to protect your foot so it has time to heal? Pain. Without pain, you don't know you've injured yourself. You don't know you need to take time for it to heal. So these people, they injure their foot, they keep on walking on it, and it never heals properly, and they keep on re-injuring it. Ultimately, these end up getting infected and they end up being amputated. Historically, ancient humans, they probably wouldn't have survived. So why pain? Well, it's going to be for protection and survival, ultimately. Now, what is pain? Well, some people think damage, well, that's not it. It's something you feel. So it's an emotion. So where does it come from? Well, it's going to come from the part of the brain where the other emotions come from. That makes sense. Other parts of the brain are also going to be involved as well. So one point in particular is that the part of the brain responsible for memory is also involved in the creation of pain. And I'm going to touch on that again, and that's going to tie into basically the rest of the presentations today. Now, together, emotion and memory, together, all the parts of the brain responsible for pain are sometimes referred to as the pain neuromatrix. Sometimes I like to refer to it as sort of the pain protection system because that's the purpose of pain. Right? So how does pain work? Well, pain sensors are going to report to the pain neuromatrix. Now, I wish it was as simple as that, but it's a little bit more complicated. Because what is a pain sensor? Right? Pain is an emotion, so what's it picking up? So it's going to pick up chemical responses. So if you get a cut, there's some inflammation, there's going to be some chemicals involved in the inflammatory process. When you tire out your muscles, lactic acid buildup, there's chemicals released there. And these receptors are going to pick this up, and this is going to refer to pain, maybe. Stretch receptors, pressure receptors, and actually you can throw temperature sensors in there as well. And I put high threshold there. You actually want these sensors to result in pain right before damage happens, not after the fact. That's no good as a protection system. Ideally, the threshold for these sensors are set so that they fire just before damage happens. So as things stretch, you want the stretch receptors to go off before something is torn. You want pressure sensors to go off before something is compressed. You want temperature sensors to go off before you're burned. Right? And sometimes movement sensors. Now you're moving your hands, there's no pain there, that's not a pain sensor, how does that work? But if you think about movement sensors can be recruited into the pain system. And if you think about pain as a protection system, this makes sense. You hurt your shoulder, your brain is going to make moving painful so that you don't move it and you protect it so that it has time to heal. So movement sensors can report to the pain parts of the brain. Now, these signals don't go straight to the brain. There's actually a layer of processing that happens by neurons in the spinal cord. I had no idea before becoming a chiropractor that there were neurons in the spinal cord. So neurons are your brain cells, they do the thinking, and there's actually neurons all through your spinal cord that do first-level processing. In fact, your reflexes happen at the level of the spinal cord. So the withdrawal reflex from something that's painful, the spinal cord thought about doing that. You didn't even consciously think about it. It happened so fast. So there's this layer of processing that happens there. And after it gets relayed to the brain, the pain neuromatrix, decides whether to produce the pain emotion. So how does it decide whether to produce the emotion? Well, it's going to be based on the amount of signal coming in and on past experiences. Here's where the memory comes in. It uses the past experience to inform it as to whether, have I been hurt in this situation before? Is this a dangerous situation? Am I in a really safe place and what's happening is actually okay? I'm going to ignore the pain signals coming in because it's not dangerous. If it's a really dangerous situation, I want to know what's going on. I'm going to warn the conscious mind what's going on, even if there's a small signal. So it's informed with past experiences. Now we can get to that definition of central sensitization. So central is going to refer to the central nervous system, which is our spinal cord in our brain. And the sensitization is that it can be more sensitive. I mentioned that there's these neurons in the spinal cord relay the signals up, and I mentioned that the sensors are set at a high threshold. Because there's sometimes low-level signals going to those neurons, but they normally ignore it. It doesn't hit the threshold such that it needs to be sent up to the brain. This isn't important enough to send up to the brain yet. But if there's a lot of signals going through these neurons in the spinal cord, the threshold becomes lower and the sensitivity becomes higher. And this makes sense for protection purposes. Okay, there's a lot of pain going through, become more sensitive so the brain knows exactly what's going on. Before, the low signals I was ignoring, now I'm going to send it all the way up. In addition to more signals going up, what happens is that pain can spread. A pain starts in the shoulder and it can go all the way down the arm. A pain in the back can start going down the leg. So a region of pain starts to spread. In addition to this, because of the sensitivity, touch can now become painful. Just touching the skin can become painful. Normally isn't, but it can be. If you think about this all in context, I hurt my shoulder, moving now hurts, the pain is spread all the way down my arm, even just touching the skin. And that's not even close to causing damage, but I'm interpreting that as pain because it's all about protecting the limb so it can heal properly. This all makes sense in context. Now, if things are working properly though, your shoulder heals and your brain is going to say, okay, everything's safe now. You can turn down the sensitivity, you can turn the threshold and set right back to normal again. But that's if everything's working properly. In a chronic pain syndrome or chronic pain disorder, things aren't working properly. The brain doesn't say, it's okay now, it's safe now, everything's okay. And because the neurons in the spinal cord don't get that signal, they stay sensitive. The pain continues to spread. It still hurts to touch the skin, right? So the central sensitization is going to persist. And remember, if the brain thinks it's to protect the body, it can make moving painful. These people with chronic pain syndromes, they have this fear avoidance of activity, of motion. And this limits their ability to exercise and enjoy life. And the body is a machine that likes to move. If those of you who are active, how do you feel if you haven't been able to go for a walk or exercise for a while? You feel awful. These people get all sorts of muscle aches and pains, which you'd barely feel for an average individual, a 1 out of 10 on the pain scale, but because of central sensitization, this is a 7 out of 10, an 8 out of 10 constant pain for them, and it's just a mild muscle aches from not moving, but they're scared to move because if the moving is going to cause sharp pains. So these chronic pain syndromes are quite troublesome, particularly in our health system because it's partly a brain problem, and they sometimes get missed. And even when they're identified, sometimes the opposite problem happens and their legitimate muscle problems get ignored because, your pain's all in your head. You can't win. So the brain is making these decisions about whether to downregulate pain or not based on past experiences. So what do you think the effect of trauma, stress, fear is going to have on the likelihood of developing one of these pain disorders? Well, here's one of many, many, many studies that I could have grabbed and thrown up here about the topic, and the conclusion is what you would expect. Here it is. When emotional pain becomes physical, adverse childhood experiences, pain, and the role of mood and anxiety disorders. And their conclusion, adverse childhood experiences were linked to an increase in anxiety and mood disorders, which, in turn, were associated with an increase in the number of painful medical conditions. So this isn't surprising. But what can we do about it? Well, people have talked all day about what we can do about it. Ideally, prevent trauma, much easier said than done. What's a little bit easier to do is to address the mental health repercussions before chronic pain develops, and that's what everyone's been talking and trying to do so far today. Where I come in often and where I see them is what to do if they're already in pain. So if they're already in pain, yes, I can treat the muscle problems, the joint problems, but that's necessary because they get the normal muscle aches and pains, and they get more muscle aches and pains than the average person because of that fear of moving. Their muscles are atrophied, the muscle coordination is off. Ironically, they're more prone to hurting themselves because they've been scared of hurting themselves and not moving properly. So these muscle and joint problems need to be addressed. But the mental health component ultimately needs to be addressed for these people to recover. These people often get stuck in a system, sometimes their whole life, for decades, where they just never get better. And I've seen cases of them actually get better, but requires tackling both these components. So the mental health component can be addressed through counseling. There's different strategies there. That's beyond the scope of this talk. And carefully worded explanations. Words can harm, but words can heal. So this explanation, if you can share this with other people, this can help people. Sometimes physicians, in particular, can take a moment to explain that pain does not equal damage. I had someone earlier this week, I used an example of cookies. You can think cookies equals happiness. That makes sense. Cookies equals happy. But you can be happy without cookies, and having twice as many, if I give you 2 cookies, you're not necessarily twice as happy. And you can be sad and have cookies. So there's the illusion of a relationship there. I say cookies equal happiness, you're like, yeah, that makes sense. But it's not quite true. There's a relationship between pain and damage, but it's not true that they're the same thing. You can have almost no damage and lots of pain, and you can have lots of pain and no damage. Physicians can help, but they can exacerbate chronic pain disorders and even cause chronic pain disorders. I get lots of people coming into my office obsessed with X-ray findings, obsessed with MRI findings, and they don't realize that a lot of the findings they're obsessed over are fairly common and normal. If I start X-raying people randomly here, I'll find some hip arthritis. But 30% of the people with hip arthritis will say, oh, that's strange, I've never had any hip pain in my life. What's up with that? Well, hip arthritis actually has a very poor correlation with actual pain experience. Now, if I go to those people who say they don't have pain and say, oh yeah, that's that bone, it's grinding right there. Well, those people are now going to have pain. So physicians have to choose their words very carefully so that we aren't creating more chronic pain disorders. We're not creating more problems. I prefer to use the words, age-related, normal age-related changes. Or your tissue is deconditioned. Deconditioned implies it can be reconditioned. There's hope. So you have to always stay positive with these individuals if you want them to get better. So, to summarize, I'm right on time. Pain is a protection mechanism. The sensitivity of the protection mechanism can be increased, and movement can be made painful if it's required to protect the body. Trauma and anxiety are linked to a persisting increased sensitivity to pain. And if we want to help these individuals, we often have to treat through counseling and physical therapy. Okay. And thank you.